Welcome to tonight's Wu University webinar, Improving Ocular Surface Disease Diagnosis with Dr. Douglas Devries. I'm your host, Dr. Jennifer Stewart, and I'm really excited to be here. So without further ado, I have the great honor of introducing Dr. Devries, who co-founded Eye Care Associates of Nevada in 1992 and has since then limited his practices to diseases of the eye and surgical co-management. His specific area of interest has been in ocular surface disease, which makes up the majority of his clinical practice. He's a director of the optometric residency program and is an associate clinical professor of optometry. He graduated with a degree in financial management from the University of Nevada and received his Doctor of Optometry degree from Pacific University. He has served as president of the Nevada Optometric Association, as well as the Great Western Council of Optometry. He lectures nationally and internationally on anterior segment eye disease. Here are his financial disclosures. I'm not going to go through them because there are many.
Thank you, Jen. Appreciate that. And it really is a great honor to be here and presenting for WuU and being able to go through this presentation tonight. Let me make sure my screen is up and running. Okay. And again, these are my financial disclosures, which have already been seen, and all conflicts have been mitigated. So what we're talking about is dry eye disease and how to really improve the diagnosis. Well, when you have a cornea like this, you really don't need to improve anything because you can tell right off the bat. But the more subtle cases, what we're going to need to do is we're going to need to dig in a little bit deeper to see if we can improve some of the diagnosis, the sensitivity and the specificity of that diagnosis as well. And so as we just look at the definition of ocular surface disease, it really is characterized by a loss of homeostasis and talks about tear film instability and hyperosmolarity, as well as inflammation and neurosensory abnormalities. And we're hearing more and more about neurosensory abnormalities and the role that they play in ocular surface disease. And so we just want to really keep these components in mind when we say, well, how do we improve testing in this? And as we look at the prevalence right now, we've seen that these numbers have actually been true. And in some cases, since we went through this pandemic, in many cases, we believe that it's exceeded these numbers and gone even higher when we put ourselves in front of the screen as much as we have done and are doing tonight with the amount of just visual display time that we have all generations utilizing at this particular time. And when we talk about etiology of dry eye, when we're looking at trying to silo and saying, well, aqueous deficiency or evaporative dry eye or mix, in my clinical experience in the years I've been treating ocular surface disease, what I've found is that everybody is on a continuum. And that continuum is going to involve every aspect of this. And you'll see some people that will accelerate a little faster and have their aqueous deficiency. Other people will have the lid abnormality start forming as a result of inflammation. And the point that I make on this is take a look at the consummate aqueous deficient patient, and that would be Sjogren's patient. And when you think of your Sjogren's patients, have you ever seen a Sjogren's patient that doesn't have MGD? So when we really look at this, I look at the continuum of dry eye as everybody is on their physiological scale, and they will progress at a different rate. And so, when I'm looking at treating, yes, I'm going to take care of lid problems that occur. I'm going to take care of and look for different patterns. But what I'm really going to do is consider it overall that in ocular surface disease, we have dry disease, we have lid disease, we have the Meibomian gland dysfunction. And as we look at other conditions and the comorbidities that exist, we look at the prevalence of dry disease in patients with allergy at 25%. And if we look over in the far right at this glaucoma and ocular hypertension, it's up to almost 60%. And when you consider a subgroup within glaucoma, that is the prostaglandin analogs, that's going to be upwards to 92%. And one thing I'd really like to pay attention to is how it affects general optometric practice so much. Take a look at 50% of the contact lens wearers. Take a look at 54% of patients with diabetes. So when we look at those conditions, I always say when we're looking at this, don't look at the rare, look at what's common, look what's in your practice all the time. And that is going to be contact lens wearers. That's going to be patients suffering from allergy. That's going to be patients that have diabetes. And then, of course, your glaucoma patients as well. Now, what we're going to do is we're going to take a look a little bit at some of the tools we have available. We see first the Inflammadry, and this is now a method of testing osmolarity, which we're going to talk about the advancements in some of the treatments. We have, looking at debriders and for the lid margins. We're looking at thermal pulsation, utilizing something like Alcon's iLux, and then microblepharal exfoliation. Then looking at other means to relieve some of the obstruction, we see the smart lids from Sight Sciences and the smart hub that actually heats it up. And then, of course, the expressors. And then thermal one touch, I use this device to really touch things up after I've done some thermal pulsation. If I want to do just a little bit more on a patient, I'll go to this OcuSoft digital one touch. And then, of course, LipiFlow. That we've used for years and has really set the standard in thermal pulsation. So, we have a lot of choices in this, but the key is really, doing a good job identifying and then making a determination which equipment you're going to acquire. And as a result of that, what I start off really talking about, and I used to put this at the end of the talks, but I really put it up front, and that is talking about, what does the bottom line do? And I will say that the idea to treat ocular surfaces not for profit is not just strictly for making more revenue, but if you're doing something that can increase the level of care that you're providing your patients and you're providing them a higher level of care, and it financially supports your practice and does well from that, then that is a total win for the service that you're going to provide. So we take a look at some of these items, and that's like punctal occlusion, anterior segment photography, amniotic membrane nose, utilizing IPL, thermal expression of the different types of procedures, manual expression, microblepharal exfoliation, Demodex treatments, utilizing then making products available to patients, having the supplements available, and then scrubs and tears and masks and moisture eyewear. All of these fit into a dry eye. And how I discovered these really wasn't from the idea that I wanted to necessarily sell them in the practice. I wanted compliance. And to have compliance, you have to make the products and the services that you're providing readily available. So then let's look at some bottom line examples. And these are right off of ledger sheets. And this would be, starting at the top, 4 visits for a patient during the course of the year, tears, scrubs, diagnostic tests, and it really comes up to a net of $577. And this isn't a gross number, this is a net number. And then you look as you add various things with the treatment, putting plugs in, putting microblepharal exfoliation in, putting thermal expression in. But as you add these with patients, what you can find is it really is a tremendous source of revenue for your practice. My practice is a medical surgical referral center that I co-founded 31 years ago. And what we've seen with this is a tremendous increase in awareness of dry eye, just simply because of the surgical procedures we're performing. And so as a result, over 20 years ago, I became involved in dry eye and looking at, trying to serve the patient's need to get better surgical outcomes. And now I dedicate 90% of my practice to ocular surgery, ocular surface disease. And I will say that when you take a look at these examples right here, bottom line examples, that there's actually times in my clinic, if my partner is doing just regular cataract surgery, that I actually will outproduce based on some of the procedures that I'm doing. So, to consider, you want to do what's going to be best for the patient, which is give them a higher level of care, which is going to make them more comfortable in their contact lenses, which is going to give them potentially better surgical outcomes. But at the same time, it actually is going to help your practice. And then going through just some tips for actually moving a dry eye practice forward. And that starts small. You already have all the equipment that you really need, and it's within your practice right now. And that is, you need a slit lamp, you need some vital dyes, and if you have some Q-tips, you really have everything that you really need. And then another tip is really utilize questionnaires. What you do with that questionnaire is that's low-hanging fruit. You let that patient tell you they have a problem, and then you can address it. And there's many questionnaires. I'll go through a few of them tonight, and that's the OSDI, the speed questionnaire, frequency of dryness, the DEQ5. So there's a lot of questionnaires that are public domain that are readily available. And then utilize the pharmaceutical reps and the device reps to do lunch and learns in your practice. I mean, anymore today, it is so difficult to maintain and keep employees within the practice that you got to keep everybody on the same page. And the people that are working, with you on your dry eye side of your practice, they should be able to finish sentences that you start. So do lunch and learns, let them get your staff together, buy them lunch, and they can present the particular product, but really what you're doing, and keep that dialogue very uniform. And the other thing is, do your own market evaluation. And this is something where you make a determination what particular service or procedure that you want to offer within your practice based on the demographics. In other words, what do you have within the practice right now? It's not my practice. It can't be other people's practice. It has to be your practice. And the patient demographics, what does that dictate in terms? So one of the tips that I'll give you, and we'll talk about on that, is, for instance, taking that questionnaire. If you're not using a questionnaire, put a questionnaire out there for a period of 2 weeks. Take that questionnaire into the exam room with you, flip it over, and then press on the Meibomian glands with a Q-tip and score the meibum that is actually present. And then you can really tell, number one, how many patients are really complaining, how many patients have good meibum, how many patients don't, and do that for 2 weeks. And then you will find out, when you go to look at, if you want to get meibography in the practice, if you want to get thermal pulsation, if you want to get IPL, it will show you within your practice what your actual demographics are. And therefore, if you're going to invest, and then you can take some very conservative numbers to make that determination. For instance, you could take all those patients for 2 weeks and say, okay, I have this number of patients, and now let's take a conversion of 10%. If I was able to convert that 10% and look at these type of procedures, how many procedures would that mean? What would be the cost of the procedure? What is the cost of the instrumentation? So do your own market research, really, or your own market evaluation within your practice itself to really see, and then just run the numbers on each investment that you're looking on. You can easily do that. Now you know from your patient demographic what you have to do, and you have an idea. And the other thing is designate a dry eye coordinator. This is the coordinator of my practice. It's been with me for 14 years. He really can honestly answer questions before, that on sentences that I start, he can finish them. And I mean, he really is in dialogue. He has a really good idea how I'm going to do this. This coordinator helps get prior authorizations. This coordinator will help really drive, and this individual will also educate the other members of your staff and keep them on pace of what you're currently doing within your practice. And then really just commit to a level of care within your practice, and plan to work, and then work that plan and have that. And then you need to determine the dialogue. You need to have the conversation that you are comfortable with in describing to a patient what the Meibomian gland dysfunction is, what the meibum should look like, what thermal pulsation would look like, what any procedures, any drug that you're doing. You have to get very comfortable with that dialogue. And if you're comfortable with that dialogue, that will translate into a tremendous amount of confidence in what you're telling the patient and them moving forward. And you'll see at that point that your conversions, because you've been able to see the results, you've been able to see the good things that have happened, the patients will have confidence, and you will speak with that confidence, and your staff will have confidence too. But really find the dialogue that you're really comfortable with. And in as we look, and we look at dry eye, of course, we look at what happened in 2007 with the DEWS guidelines, and saw that in 2017 they were completely different. And of course, hindsight is always 2020. And this picture really reminds me, and this is totally dry eye. This is what dry eye is all about. I'm in a convention center in Oregon. And I look out the door and I see this sign that says free beer, and I'm thinking, well, oh, what a nice thing that is. It's a restaurant that's handing out free beer and a pub. And then it's just like dry though. You gotta look a little bit closer sometimes. And when you look a little closer, you realize that it's free Wi-Fi and great beer. So that is dry eye. Sometimes you just have to look a little bit closer, and that's why I say, when you have that questionnaire that you're looking and patients have symptoms and then you're pressing on the eyelids. If it looks like this, if it looks like baby oil, that patient doesn't have a problem with meibomian glands. But if it's thick, if it's turbid, if it's starting to get paste-like, this is what's really going to help you determine whether or not that patient has a problem. And in this particular example, this is a great case that, I had a resident come up and showed me meibography, and the meibography had full meibomian glands. They were a little dilated, a little bit segmented, but pretty good. And I said, well, what did the meibom look like? Because you just showed me the structure, but what is the function? And the resident said, well, look at the meibography. It's good. I said, no, show me the function. Let's go in and let's press on the eyelids. And we press on, and this is what, even though the meibography was still looked like it was okay, which is great news because you'll get good results because it's still intact, but this is what it looks like. And this isn't going to do a very good job of keeping and holding the tear together. So the standard patient evaluation of eye dryer, or the speed questionnaire, something that I personally use within my practice, and who gets it? Any returning patient. Anytime they come in, they'll have this because things change in people's lives. Sometimes they may not have that level where they're quite ready to start treatment. If you monitor with the speed questionnaire, you'll have a good idea. The other thing that the speed questionnaire does in my practice is it generates point of care testing. I don't have that where I have to see a patient. If they have a 6 or above on the speed questionnaire, they automatically generate point of care testing. And at that point, my staff just takes over. They see that. So before I've ever seen the patient, we'll go through some of the tests. You can do that also with the DEQ5, which is another standard validated questionnaire. And this way, you'll never be questioned by an insurance company for the test you run, because it is based on a validated questionnaire and a certain number that you pick that generates that point of care testing. Now, what do you need to do point of care testing as we start to get down to the diagnosis? And that is, you need to have a CLIA waiver, and that is the Clinical Laboratory Amendment Act. And what that allows is you to do CLIA waive tests within your practice. In other words, it is you become the lab director and you bill the test as a lab test. It has different deductibles. It does not affect your E&M codes. And each state will vary a little bit. There's a national CLIA that you apply for, and then there's the state CLIAs that you have. Very easy in most states to acquire, but this allows you to do CLIA waive tests. And of course, you're going to keep logs, you're going to keep the tests you do, you're going to keep the standards on that, but very easy to maintain. But it allows you then to perform these tests within your practice. And again, speed score of 6 or greater. In a typical practice, that's going to be anything between 15 to 20% of the patients. In my practice, it happens to be much higher, just simply because of the population that I'm seeing as cataract patients and refractive surgery patients. And the investment all depends on utilization in terms of what you're actually going to get. And again, if you've run these numbers, if you've taken a look at this, you will then know the percentage of your patients that could perhaps benefit from some of the testing, some of the treatment that you're going to offer within your dry eye clinic. So let's talk about osmolarity testing. As you saw in the definition, osmolarity testing was one of the defining features of ocular surface disease, an increase in osmolarity. So in other words, we're measuring the solute concentration of an individual's tears. And what are we looking for when we see normal osmolarity? It's going to be somewhere under 300 milliosmoles. And in this case, when you have something like 290 and the inner eye difference is only 2 milliosmoles, then we know that it's a normal osmolarity. When we're looking at abnormal, that means that as it gets over 300, and just because there's that gray area there between 300 and getting just over that, we've really determined that at 308, it definitely is dry eye, or an inter-eye difference of greater than 8 milliosmoles. And if you have an inter-eye difference of greater than 8 milliosmoles, then that is just like taking an IOP and finding a big variation between the two eyes. That person definitely becomes suspect at that point for dry eye disease. So really, if a patient is symptomatic and has normal osmolarity, but they are symptomatic, you need to start looking in a different direction. But the osmolarity will help you. It could be conjunctival chalasis. It could be mild allergic conjunctivitis. It could be epithelial basement membrane dystrophy. And one of the stories I like to tell about Louis is he took a case history on a patient and found out, what their symptoms were, when their symptoms were. He did the osmolarity on the patient, which was normal. He also looked at the inflammation, to the inflammation test. And he came out, he handed me the chart, and he goes, $10 says that it's epithelial basement membrane dystrophy. I thought, well, let's go in and see. And sure enough, he actually followed some of, what I've been doing over the years, and he could put those pieces together. So, and that's what it was. So when we look at tear osmolarity, what is the big deal about it? What happens when we get hyperosmolar tears? And what happens is that we have this glycocalyx mixture in the microvilli, and what that does is that retains moisture on the corneal surface. And when we have a decrease in aqueous production or an increased evaporation, then we can have an abnormal osmolarity. Well, what happens at that point? What happens is we end up having increasingly cytotoxic elements to the corneal epithelium. And when we look at those it looks like little cracks in the epithelium there. That's breaks in the cell membrane. And when we start seeing breaks in the cell membrane, how is that going to manifest clinically when we look at it? Well, that's going to be the PEK on the cornea. That is going to be when we get a split in that cell, in the cell membrane, where we start to get that desiccative stress that actually causes that epithelium to start having breaks in the cell membrane. And then we'll see that. And a word on staining as well. Just when you look at these pictures, it has to start at a very subtle stage. It doesn't just start at that lower right-hand picture. It starts that break in the cell membrane. So when you put fluorescein into the eye, and make sure you use fluorescein and not fluoresce, because that obviously has a numbing agent in it, either binoxidate or fluorescein, or fluoresce has the proparacaine in it. But when we look at just fluorescein staining, let some of the fluorescein clear out. Otherwise, it's going to just mask, and all you're going to see is the big staining, like it'd be in the lower right. You wouldn't see the more subtle or the micropunctate staining that happens initially with the patient. So let's take a look at these graphs and what these represent. And in osmolarity, if you have a patient with normal osmolarity, you can test, you can retest, you can retest, you can retest, and that is going to maintain consistent readings. If you look at the lower right, where we take severe dry eye and you test and retest and retest, those numbers are going to be up and down. They're going to be up high because you're going to get a reflex tearing. You're going to have where that salt content is going to drop. So just remember this with osmolarity, is that with osmolarity, you can get a false negative. You can get an artificially low number. You cannot get an artificially high number. If it's high, that osmolarity is high. If it's low, it could be a reflex. And that's why we test both eyes. And that's why we look for a difference between the two eyes of greater than 8 milliosmoles to help us determine that. So even if you were right around 300 and you had something that was 10 milliosmoles, that becomes suspect, and you have to start looking at that a little bit more. So when we take a look at the prevalence of tear film hyperosmolarity, in this study there was almost 10,000 patients, and the percentage of patients with one dry eye symptom was 81%. The number of asymptomatic patients with abnormal osmolarity, I think this is a key, that 60% of those, and they're asymptomatic, but things are changing. It's really important. And if you could identify that with your contact lens patients, when things are starting to change, that's when you take some action. That's when the early action could perhaps keep that patient from becoming a contact lens intolerant individual and switching practices. So, and again, that's based on inter-eye difference as well. And then the patients exhibiting moderate hyperosmolarity, 29% out of the 10,000, moderately high osmolarity. And then the percentage of symptomatic patients with normal osmolarity. Again, you need to look in a little bit different area. You need to actually retest that patient again. And we talked about the normal versus abnormal. Now, all that's involved with this, and now this technology has really evolved in just the recent future before, and we'll look at how it was done before, which may still be in some practices, and then how it can be done. But this little collection tip that we use, it's just a very, very small microliter amount of tear that gets up into those channels, as you see. And then now in this handpiece that is with the Trucara Scout Pro, everything is contained within half. Now, this you're going to see is the osmolarity being tested, and some people may still have this instrument. It is still made by the same company, but here's the test tip. This is exactly the same thing that happens with the new instrument. Now, what you'll see is he won't put this in toward the eye. He just drops it onto the eyelid. And then that little light blink, that indicates he collected the sample and then went back to the base, put in the lot number, and in real time here, we'll see that we get a readout of the milliosmol. So that is what has previously been done. I want to show you what now, and it makes it ergonomically so much better for your practice. And that is, now look at this, and there's a timer up here. The same tip goes on. You're going to collect the sample. And there is no docking. Everything you can actually do. And under 15 seconds, we've prepared it, we've collected a sample, and actually have the osmolarity. So it's really expedited, and you don't have to juggle two handles. You can just really work with one. So testing osmolarity, the initial investment on this is going to be about $9,500 for that Scout Pro. The test cards are about $11 per test card, and you use one test card per eye. And again, it's billed as a lab test. The reimbursement averages somewhere around $22.48 per eye. So it does create downstream revenue, but that is, I mean, the reason you do it is not the immediate revenue. It's what happens downstream as a result of doing osmolarity. Patients love numbers. If you give patients, the first thing your patients will do when you pull away the tonometer tip is they're going to ask you, what was my number? What was my interocular pressure? They love these numbers. And so this helps maintain. It not only helps you in guiding and differentiating some of the diagnosis, but it'll also lend to actually the confidence of the patient. Let's say that you're treating a patient and the numbers are coming down, they're getting better, and the patient says, wow, you know, I feel maybe a little better, about the same. And you say, well, your numbers are really, really looking a lot better. They accept that. They like to have that. Of course, they want all of their symptoms to go away if they are symptomatic, but at the same time, if they're seeing a diagnostic test and a lab test that's showing improvement, they do really like that. And I found that out in initially doing some of the beta testing on these type of devices, when we had to have the patient pay for the actual test, and they were signing a waiver that they were part of a data collection, but they were paying $25 an eye. And those same patients would come back in 3 or 4 months and say, aren't we going to do that test again where we look at what my numbers are? So even though they were having to pay for it, they still wanted me to have that information to help guide me. So again, the allowable range that we have, somewhere the cost of buying the card is going to be about $22 for both eyes, but the reimbursement is going to be from anywhere from $12 to $23. So that's $24 to $46. So it will generate a positive cash flow, but that's not the reason to do it. The reason is in helping you pinpoint, in giving the confidence in the patient, and maintaining their treatment. Okay, so that's osmolarity. And the other point that was mentioned in the definition of ocular surface disease was inflammation. So looking at MMP9s, that's just matrix metalloproteinases, and there's just simply a proteolytic enzyme that are released by stressed epithelial cells on the surface, and that can be released from anything. It's non-specific. It doesn't mean dry eye. It means there's an inflammatory present, or those epithelial cells are stressed. So EBMD can do that. An allergic conjunctivitis can do that. Rubbing the eye excessively can do that. And really, it tends to have a nice correlation with clinical signs as well. So as we look at all the different activation of some of the inflammatory markers, MMP is just simply one of those that has been identified and been approved for point-of-care testing. So as we look at the increase in the desiccating stress and the increase in the MMP9s, this really helps guide treatment on how you're doing. Are you lowering that treatment? Is the treatment still out of control? And we'll show you how you actually grade that and you look at that. But what we find is that MMP9 really destabilizes the tear film. And this is what happens with that whole breakdown, that whole increase in osmolarity, the breaking down of the tight junctions. And that is all from inflammatory stress of the matrix metalloproteinases. So as we see that, so if we can actually identify that through our treatment, that we're making progress on that. And again, like I said, with that test that my technician did, he did the case history, he listened to when the complaints were, he did osmolarity, which was normal, and then found a high MMP9. And that's when he came back to me and said, I bet it's epithelial basement membrane dystrophy. And sure enough, he was absolutely right. So really, the MMP9 testing is a very, very simple type of test to just really help aid in not only the diagnosis, because in many cases you're saying, well, I'm already going to treat this patient anyway. What good does it do? Well, once you're treating the patient, you can see where that test is swaying from that particular level. Now, as we look at this is the windows that we're looking at that exposes. And when you look at that very, very faint pink line in there, that very faint pink line indicates that is a positive right there. So that would, and I would actually chart that as faint. I would put faint, mild, moderate, or severe. So I can see in subsequent tests is how is that trending? Where is it going? Am I on the right track for lowering inflammation? And a lot of times when you're really hitting them with anti-inflammatories and you're not seeing a response, sometimes you have to shift gears and find out what else is that patient doing that could be creating that kind of inflammation. As we look at rosacea and MMP9s, and of course that makes sense. I mean, we have the rosacea. We have patients with rosacea are going to have a much higher percentage of Meibomian gland dysfunction. And as we see these numbers, it correlates very well. Post-LASIK, dry eye and MMP9s. In these studies, what it showed is an elevated MMP9 as we were going post-LASIK. Why? Well, you've cut the nerves. Remember that neurosensory abnormality is part of the definition. So it really helps to identify. Now, when you take a look at treating and you take a look at MMP9s and artificial tears, it has failed to demonstrate any reduction in MMP9 levels just simply with artificial tears. If you were to use an artificial tear and test osmolarity, it would be better, but only because of the dilution factor, not because of a healing factor that we have. And punctal occlusion. And we've seen that with punctal occlusion, that can really help the ocular surface, but we don't want to occlude while we have inflammation. So what's a great way is make sure that inflammation is on a downward trend before we actually look at doing punctal occlusion and going into our treatment protocol. So this really allows us to look and see where the inflammation is coming from, look and see what the level, and then see what our treatment is actually doing for that. So how are the patients really responding as we start and we do the treatment? Now let's take a look at the MMP9s. And right here, what we're doing is this is actually the cassette. Now and what he's doing is he's writing the time and the eye on the back of the cassette, because the exposure of this takes somewhere around 10 minutes. Now, the second part of this is actually a sample collector. So this is how we collect the sample for the MMP9s. Now, and we'll get around to the side and get from away from the hand so you can actually see what he's doing. He's actually dabbing on the conjunctival tissue. He goes once temporal to nasal. He's going a second time temporal to nasal. I'm holding just a little bit on the nasal. That's just assuring that we have an adequate sample of the tear. Now he's going to snap that sample collector into the cassette. And that wick that you see there is actually going to wick up the reagent that will react with the MMP9s and push that into the window. And as that pushes that all the way up, then we get a blue line indicating that the sample has been pushed up. Now all we're waiting for is the exposure. So what my technicians will do is they'll set it on the exam room desk and they'll wait till I come in. So very simple test to perform. You see he's closing the cassette and he'll just set it on the desk like that. And then I'll come in and read it directly from the window. So now, as we shift to MGD, we see how incredibly common it is with all sorts of different comorbidities, whether it's cataract patients, contact lens wearers. Again, look for the ordinary that's in your practice. Your contact lens patients, your patients have cataract, your glaucoma patients. As you look at the common, and of course, the overlap with dry eye is about 86%. So when we take a look at diagnosing, really gland expression is going to be the key. Gland expression combined by meibography. I told you as one of my residents presented meibography and said, this looks pretty good. They must not have MGD. When we looked at the expression, then we see difference. So it really is a structure and a function change that we see as we see the stages where these little ducts start to collapse, start to atrophy. And we know that the impact that we're going to have with MGD is going to affect the corneal nerve health, the conjunctival health, of course, the immunity of the tear film. It's going to affect visual acuity. And of course, what's going to be so important to most optometric practices is contact lens comfort and wear time as well. Now, this is where we get into the structure versus function. Again, looking at the imaging of the Meibomian glands, as you see on the bottom, very analogous to looking at the structure in glaucoma. And we wouldn't just strictly look at structure in glaucoma. We don't just look at structure in Meibomian glands. It's great. And this is an incredible way of educating a patient as to what's actually happening when they start to get obstructed and we start to see that drop out. In the middle picture, you see the middle of the Meibomian glands and they're starting to shorten, they're starting to dilate. And in that right-hand picture, they're really accelerating on that. So when you see meibography and you do this, and in my point of care test, we use osmolarity, inflammation, and meibography. Now, meibography is not billed as a point of care test. It's not billed to their insurance. However, I think it's the Snellen visual acuity of dry. I think it's so critical because patients truly understand when they see, when they are able to actually see how their glands are dropping out. So I think that, a meibographer, that could very well be somebody's initial investment in getting in, and because it's gonna help convince that patient. Because when I see Meibomian glands that are starting to atrophy, what I will tell that patient is, I can't allow you to continue to lose those Meibomian glands. And it's with incredible sincerity, because I have seen those patients that are very advanced when they lose their Meibomian glands, and they become very uncomfortable. So when I tell them, I just can't let you do that, we're going to have to do something about the structure, and we're going to have to do something about the obstruction. And in this particular case, you can see on the image, we put it up on a 42-inch screen so that patient can really see what that dropout looks like, and then show them a chart and be able to compare with what they what normal is and what their actual glands are. And when that ties into the symptoms of a patient, you have a patient that is willing to do things to actually make it better. And you can see the capturing here. This will be the capturing of the meibography, how simple it is. Rather easy. The technicians can do this very, very quickly. And in this particular picture here, before the meibography, what we're doing is actually we're looking at the thickness of the oil layer. Because of meibography, I rarely find the need to even do that anymore. Again, as we see the changes that have taken place between 2007 and 2017, MGD was not even mentioned in the DEWS report in 2007, and it became of paramount importance in 2017 as it continues to advance. So we really see that now we talk about doing in-office IPL, in-office thermal pulsation at a step level 2. So take care of the immediate inflammatory response and then take care of the damage that has been done. Okay, so now we're going to get into looking at one of the most important diagnostic questions that you can ask in your clinic or of any patient that is complaining of dry eye disease. And that is, do you have morning symptoms? And the reason that is so important is we've really discovered that a lot of these patients above age 45 could be up to 75, 80% of those patients actually have inadequate lid seal. And when a patient has inadequate lid seal, you're dumping on anti-inflammatories, you're taking care of the damage that has been done with the inflammation that we saw in the loss of Meibomian glands, the dilation, the segmentation, the obstruction, and how that Meibomian gland starts losing its function, how the osmolarity, but we haven't really identified any root cause. But if you ask that patient, do you have morning symptoms? When you wake up, do you feel like putting a drop in first thing in the morning? Then what we're doing is we're actually identifying root cause. We're getting to the root cause of why, when we're putting anti-inflammatories on, the patients aren't responding. Why, when we just use one of the dry drugs. And of course, with the dry drugs now, we have really a multitude of them now. For years, all we had was cyclosporin, 0.05% Restasis. Then Xiidra or lifitegrast got released, which is an LFA1 antagonist as opposed to just a straight immunosuppressive. And then Cequa got approved, and Cequa is a nanomicellular in a 0.09 concentration, getting a lot higher concentration. So we're seeing these improvements. And then Isuvis comes along and is approved for dry eye, and Oyster Point gets Tyrvaya approved. So we have a lot of things that we can put on. The Tyrvaya is going to be a neurostimulator that is actually going to create more tears and help that patient. But let's get down to the root cause of why did those tears turn south? Why did the morning symptom? This is one of the most important questions you can ask. And if a patient says, hey, my eyes are absolutely perfectly fine in the morning, then we haven't identified that as having the inadequate lid seal. So the ILS that we're seeing now and understanding more and more, and I've seen this in my practice for years and years, how that inadequate lid seal can really start driving it. And one of the things you can do is you can do the core Blackie light test. Now, you can do this to validate, but that symptomatic question of, do you have symptoms first thing in the morning, unless they have a raging blepharitis or a Demodex blepharitis that is just out of control, the morning time should be the best time. They shouldn't wake up at night and their eyes shouldn't be dry. They shouldn't wake up in the morning and feel the need to put a tear in. And when that's occurring, what we have is those lids are, and we're not talking about frank nocturnal agophthalmos. Now, you'll see in this particular picture, and this, all you're doing at this point is you're having the patient lean back against the headrest, gently close their eyes, you darken the room, and you put a transilluminator on the upper lid. And you can see on this lid right here where it's seeping light. That's how that patient then is going to sleep. You have them gently close their eyes, but that is an inadequate lid seal. And what that's going to cause is constant inflammation. Now you're in that fight of saying, okay, can I put a house fire out with a garden hose? So using anti-inflammatories and the patient is still symptomatic. They're not getting better. Why? Because we're not addressing the root cause. So this cord blocking light test will really be good to do that. But all you really need, if you want to validate it with this, you can do that. But all you really need is to ask that simple question: how do your eyes feel first thing in the morning? The most important question that you can ask a patient, and what I consider so diagnostic at this point and is so accurate. Again, look at this now. This particular patient would be a frank nocturnal lagophthalmos. A lot of the inadequate lid seal is not a full nocturnal lagophthalmos like this patient, but you can see that gap here. Now, pay particular attention to your patients with sleep apnea. I learned this from a pulmonologist a number of years ago when I told him that I have a really high percentage of my patients that have sleep apnea that have nocturnal lagophthalmos. And he looked at me and he said, yeah. I go, what do you mean, yeah? He said, you know, Doug, we videotape them. We film these people while they're sleeping. We know they don't completely close their eyes. And I said, well, what percentage is that? And he said, if it's not 100%, it's darn close to it. And now there was just some recent pulmonology publications that came out looking at this study and showing that. And at the time I said, you know, you might want to have shared that with the ophthalmic community, because this was years and years ago. And that's when I started really talking about this from the podium. But again, what will be detected on this is, how do your eyes feel first thing in the morning? Do you feel the need to put a drop in? Do you have the morning symptoms? And then you can look for this inferior linear pattern on the cornea as you start looking at these. Now, these are going to be more advanced. And the interesting part about these corneas is, if you then test corneal sensitivity, they do this for so many years, usually is hereditary. It can be induced if the patient has a blepharoplasty, but many of these patients have done this just from birth. And now that cornea is so desensitized. If you take a cotton wisp or a dental floss on that inferior across that PEK, they have very, very little sensation in there. And that is that beginning of the neurotrophic keratitis. Again, look for the common within your practice, but ask that question, how do they feel first thing in the morning? And you'll also see this conjunctival staining as well. Some patients will have Bell's phenomena where their eyes will roll up. When they close their eyes, other patients don't, and they will actually stain their inferior cornea. So really a very, very, very important diagnostic that you can save yourself a lot of frustration. So then what do you do with that? And how do you take care of that when you start to see it? Well, you got to keep the lids closed. So what you want to do is you want to use something like this. This is called Sleep Tight, and it is a hypoallergenic, latex-free, porous material that when the tissue is really cleaned on the lid, it'll actually serve to keep that lid completely closed all night long. And if they clean the tissue and then put that on, they move their hand, they won't see any motion. So just putting that on, there's sensitive versions as well, but it contours to the orbit shape and will keep that eye closed. So, you know, if you use the moisture goggles, if you use sleep masks, things like that, those eyes are still open underneath that to actually be able to, and you will see wonderful things happen on how these patients now react to medication, how well they do with the treatment you're doing, how you can really slow down the net progression that we see. So, you know, take a look, ask them this question, going to be very, very important question as we go along. This is showing proper placement. It can actually be angled down about 30 degrees too to keep that eye closed. But it's such a simple concept. Make the eyes work, the eyelids work the way they were designed, and that is to stay completely shut. So those are some of my tips on diagnostic testing, elevating, getting into more of a ocular surface disease.